Good morning, everyone. So I'm Fiona Singh. I'm one of the radiologists at Wigan. Shall I just point at you for the next slide? Yeah. So just an overview. So I'm going to talk. I've assumed little to no knowledge of ultrasound and how the machine works. So apologies if you are proficient at ultrasound and just wanting to learn neck. But it's going to start from very basics. So how's the beam generated? How do we get the image? What equipment do we need? What buttons do we press on the machine? Which are the important buttons? And any sort of, I'm going to give some imaging examples and pitfalls in imaging as well. So ultrasound, it's basically high frequency sound waves. So it's over 20 kilohertz, and these are inaudible to humans. So that's the definition. So on an ultrasound machine, you have a transducer that emits an ultrasound pulse. And then the same transducer also receives the reflected echoes, and images are produced by very clever algorithms within the computer. So the probe is a very important piece of equipment. Next one. So it all hinges on this phenomenon called the piezoelectric effect. So you might remember this from physics at school. So it's the ability of certain crystalline or ceramic materials to convert mechanical energy into electrical energy, and then the reverse piezoelectric effect is electrical energy into mechanical energy. So that's how the ultrasound is generated and received as well. And it was first used it was developed for sonar in World War I. Yep. And so the frequency of medical ultrasound is 1 to 15 megahertz. So for neck ultrasound, we're at the top end of that. So you can alter the frequency of your ultrasound beam on the machine. It used to be you were changing, when I first started, you were changing numbers. So frequency, I don't know, 10 to 12 to 14. Now on the modern machines like these, it tends to be, you have a preset, for example, a thyroid preset, and then you might start at the general frequency and you can flip up to high frequency or flip down to greater penetration. So there's basically a trade-off. If you're using a high frequency to scan, your beam won't penetrate deep, but you will see high resolution superficial things. So great when we get sent very superficial skin lesions, things just below the skin to interrogate. And then low frequency, if someone's got a huge goiter and you want to see really deep down, drop the frequency and then you can see deeper down in the neck, but you're not going to see the fine detail like the fine spongiform texture of a nodule, for example. Yeah. So acoustic impedance is really important. So this is the ease at which the sound travels through a material. So sound travels less well through air, better through water, as we know when we're swimming underwater, and well through bone. However, you've also got to counter in the reflection at the boundary of different materials. So between gas and soft tissue, almost all the beam's reflected. So that means you can't see what's happening between that interface deep. I'll show an example in a minute. A lot of it, at 30%, is also still a lot of the beam. That's reflected between bone and muscle. So you won't see detail deep to the cortex of a bone. But between fat and muscle and different soft tissues, there's a small amount reflected, and that's good. So you can see the different textures between the tissues. So that's where ultrasound comes into its own. Looking at soft tissues, fat, muscle, tumours, etc., collections, fluid. Next slide. So this is bowel gas. This is just things I've pinched off the internet. But this is bowel gas. This will be an abdomen. So you can see deep to this bowel gas, you can't get any information. It's just a shadow. So bowel gas, not cool. This is a bone, some kind of long bone. This is a bit of periosteal reaction. So you can see that really nicely. But deep to the intact cortex of that bone, you can't see any information what's going on deep to that. You can, though, sometimes use it in the mandible to see defects, infections. You can sometimes see very fine fracture lines that you can't even see on X-ray. So it is useful in some respects for bone, but not for seeing deep to an intact cortex. Next slide. So Doppler effect, so this is something that I vaguely remembered, I think, from A-level physics. So if you're standing on the pavement and an ambulance whizzes past, the frequency of the siren that you hear appears to change. It's an apparent shift in frequency. It's not an actual shift. It's the same siren as the ambulance is driving. But when you're standing there, when it's whizzing towards you, the sound waves are getting, the frequency's apparently increasing, and then it apparently reduces as the ambulance goes away. That's where it makes that funny noise. I'm not going to try and do it. So that's what the ultrasound machine is using for the Doppler effect. So it's using the sound beams reflected off the blood cells and the component of blood that are flowing through the vessels. And it's this shift in frequency that the machine can then interpret as flowing blood. So it's a reflection from a moving object. So think of an ambulance whizzing past you, you're stood stationary on the pavement, and a shift in frequency. Next slide. So this is a typical Doppler image. So this is carotid artery, jugular vein. And the thing, just to tell you, if it's a red colour, that means the direction of flow is towards the probe. So I know that the blood in that carotid is flowing in that direction because it's towards the probe, and the internal jugular vein flowing that way. You can do all sorts of fancy things, but in the context of a general neck ultrasound, you don't need to do this. That's more for vascular ultrasound. But I use it all day, every day. For every lump I see, put the the colour Doppler on and see what the vascularity of the lesion I'm looking at is. And that's really important in the neck. So just everything you find that shouldn't be there, put the colour Doppler on. What does it look like? So next slide, please. So type of probe. This is the type of probe you pick up. So it's a linear probe. You want a small footprint, so the footprint's the bit that's in contact with the skin, so you can get into the nooks and crannies around the neck. You use a preset on the machine I use. It's the thyroid preset's really good. This sort of probe you would use on an abdomen. That's a lower frequency probe, and air is the enemy, so you need jelly. I can see jelly round the room like this. Beards, I was thinking on the way here, are also the enemy. So big, fluffy, bushy beards, vain men, hipsters that don't want to shave their beards. It's very tricky. It reflects all the light. You can smother it in gel, but it doesn't quite work, and it's obviously not great for procedures, for sterility. Yeah, and this is called time gain compensation. If you're getting to like more advanced, making your picture look really good, if the bottom bit of your picture looks dark, you can flick these buttons over this way and they'll make it look brighter. There's lots of things you can do to fiddle with your picture to make it look better. Next slide. So it looks a lot like the machines around here. So you've got a monitor, here are all the controls, you've got the probe or the transducer, jelly, adjustable couch is really useful so you don't knacker your back. I have the patient reclined. I think we'll go through this probably later. Neck extended. If you want to save your images to PACS, you're going to need network access. And I just added this on for this talk, but air conditioning is really important. So in our breast unit, we've just added a third ultrasound machine. It's all ready to go, but no one wants to work in there because there's no air conditioning in there yet. So ultrasound machines are basically like a big radiator. So you will really struggle, even in winter with windows open, you can really struggle to work. So it's just a thought if you're setting up a big, decent, powerful ultrasound machine. Next slide. So I tend to put the pillow low, so extend the neck and the thyroid sort of pops out a little bit there. And then varying degrees of sitting up, usually about, I suppose, 45 degrees. But it doesn't actually matter that much. And you can change people depending on what you're doing. Next slide. Oh, right. Couch height's really important. I think of it like a kitchen work surface. That's the kind of height you want to be doing procedures at. Couch position. I see people, trainees are always scanning like this. So it's like move the patient down and scan like this, not like this. Use both sides of the couch. I think that's really important. So doing procedures, go from the usual side would be the patient's right, so you're doing a procedure here, but go around the other side as well and try and have your eyes your needles and hands and the monitor almost in a line. If you're going like this, you're going to really struggle. Then when things start going wrong, bleeding, then you're really going to struggle. So a nice, comfortable line is the best way to do it. Yeah, next slide. So different types of machines, just sort of bit more modern, bit older, but they all do the same thing. Some kind of modern looking laptop machine here. I'm sure we'll all be using different machines, surgeons versus radiologists and sonographers. Next slide. So I saw this on the internet. I've not seen this before. It some magically beams the images onto your phone. So she's very pleased with herself. I've not seen that in real life, but obviously it's got lots of applications. You know, I would imagine in emergency medicine out and about would be really useful. Next slide. So if this is the kind of thing you're faced with when you approach a machine, this is the probe to pick up. So small linear one. This is the one for things like transvaginal rectal ultrasound. This might be used for cranial ultrasound on a baby, and this would be more abdomen. Next slide. So just to show you the kind of buttons that I would be pressing constantly. So freeze and still store, important to save your images. This was gain, so this is like brightness 2D or gain. So just whiz that round clockwise, the image gets brighter. Press this to put your color on, and then again you can turn the button to alter the color gain, increase, decrease. If you're getting lots of interference, it's up too high, so reduce it. So you've got to fiddle with it to get the right kind of level. The depth is a very important button, which would be this one, I think, on this machine. So you're increasing the top to bottom length of the image. And the other one, which I use a lot, but some machines have an autofocus. I really like an old-fashioned focus, so it's this button on this machine. Focus is important. I'll show you an example why. Body mark, so make sure you've got the right side. You make sure it's, you know, right, left, wherever you're scanning. And I think that's probably about all I use. That's it. Time gain compensation there. Next slide. So depth is important. So if you are scrutinizing this fetal sac or whatever it is, when you start to interrogate it, I would drop the depth because the machine's working less hard and you get a much nicer image. Otherwise the beam's having to go right down to the bottom and back and forth. So drop it. Obviously, if you want to search deep, put the depth down. But when you find something to interrogate it, get it to fill the screen like that because you'll get a better quality image. You can also zoom as well. That's a different thing. Yeah, next slide. So this is an example. This is actually a breast, an image I took. So the lady's got an implant, but I just wanted to illustrate how important the focus is. So you can see here, this is where the focus is on this image. So it's in the wrong place. And I would probably call that roughly normal. And then if you move the focus to the top on this image, there's a cancer there invading the skin. So if your machine does have a focus, I would use it for every time. You change it a lot depending on what you're looking at. Okay, next image. So none of the other parameters were changed, just the focus. So posterior acoustic enhancement, you see that with cysts. So the beam's coming down and traveling really freely and easily through the cyst because it's just fluid, nice clear fluid, no particulate matter. So you get this posterior acoustic enhancement. And then the other way to confirm it's definitely cystic, because there are some pitfalls to this, is put your colour Doppler on and you can see none of this should have any vascular flow in it, which it doesn't. So perfectly happy. They are definitely 100% cysts. I think that's a testicle, but it could be the thyroid. They look very similar. They do. Right, next. So this is also a cyst, but this is a hemorrhagic cyst. I think this is an ovary, this image. So it's got particulate matter in it. So it makes it look solid, but it's not solid, it's a cyst. And then colour Doppler on and there's no flow in it. So sometimes it can be confusing in the thyroid and you have to put a needle in. But so things with particulate matter, hemorrhage can look echogenic, but they're still cystic. If you put a needle in, aspirate, it still collapses. Next slide. calculi, so we'll come across these in the head and neck. So basically it looks like a little stone, and if it's dense enough you'll get the posterior acoustic shadow coming down here, so the opposite to a cyst. I mean, this is quite good because depending on how densely calcified, this one has a shadow, this one doesn't, but they're all calcified. Some of them are a bit more kind of crumbly and less dense. That's a salivary gland, that's a gallbladder. So there we go. Next slide. Okay, all right. Yeah. So this one, I've just got to put the needle in here. Can you like go forward a couple and go back? So I just wanted to illustrate parallelism. When you put a needle in, the more parallel your needle is, and then go back again. So I'm just doing quite a minor sort of manipulating the needle inside the tissue, but you can see as it gets more parallel to the probe, you can see it much clearer. So if you're going in with a really steep angle, you're not going to see your needle. So parallel to the needle. So you have to plan your approach well. Parallelism is key. Okay, next. And this is again just a minor adjustment on that needle. That's, I don't know what, it's thyroid, I think, a thyroid nodule, I think. And then you can see the needle much better. So that's all I've done. I've just kind of gone like that, a couple of degrees, but it makes a huge difference. Yeah. And a way to help you with parallelism is to flip the edges out on your ultrasound beam. So there's usually a button called wide angle or trapezoid, or sometimes it's just a little image that looks like that on a button on the machine. So you're changing your beam from this, so you're sort of flicking wings out at the side to this. So that helps you see the needle because it's making the beam perpendicular to your needle, if that makes sense. And you're getting a small bit of extra visualization. So trapezoid or wide angle is really useful for ultrasound guided procedures. Yeah, next slide. So pitfalls, a lot of adipose tissue is difficult. Some people who actually aren't that fat just seem to have reflective tissues. I don't know if anyone else experiences that. So everyone's different, but yeah, in general, the more adipose tissue, the less penetration your beam's going to get. Short neck, some people just have a short neck with no gap between the chin and the clavicles. Movement and swallowing, people who are very short of breath, it is tricky. I tend to not tell people, I don't mention swallowing at the start of the procedure because I think once you start saying don't swallow, they start swallowing non-stop and looking really anxious. So I wouldn't say the S word, just get on with it. Say lie down, you know, chat to them, distract them and just get on with it. Don't sort of, make a big deal about swallowing. Okay, next slide. Depth of view. So in the carotids, in the head and neck, you don't sometimes get a good view of the deeper parts, especially if they're fatty like this. This is a CT scan, that's quite a fatty carotid. It'll reflect lots of the beam back. So they're all quite variable, different amounts of fat. So ultrasound sometimes can't see very deep structures. It just can't reach there. Next slide. So this is a bit of a trap. I think Vina might mention this later, so I don't want to step on her toes. But I just wanted to mention, because I said about cysts and posterior acoustic enhancement, but there are also things that are not cystic that show posterior acoustic enhancement. So this is a solid lymph node. It'll be a lymphoma is usually the classic pseudocystic thing. And the sound beam, just because of the constituents of the node, is traveling really easily through the node. So you get this posterior acoustic enhancement, but it's still solid. So it's a trap, it's a trick. So what do? You put the collar on, next slide, and then it's alive. So it's not a cyst. So yeah, things can look very cystic on ultrasound, but not be cystic. So just be aware. Or that's why I say always put your collar on, twiddle the button. So it's non-Hodgkin's lymphoma. Artifact, there are a few artifacts you need to be aware of in ultrasound. So it's basically distortion of a substance or signal which interferes with or obscures the interpretation of a study. Or a structure that's not representative of a specimen's in vivo state, or which does not reflect the original sample. I think I need to summarise that a bit. But yeah, so that's the sort of definition of an artifact. Next slide. So you'll see this all the time when you're putting needles in, reverberation. So you see 70 needles instead of 1. Can be a bit confusing, but you get used to it. Next slide. But reverberation is useful in ultrasound of the thyroid because you're using it to see this comet tail artifact. So you get this kind of comet tail coming off the back of colloid crystal. So that is useful for reverberation artifact. Next slide. Another pitfall, just thought I'd mention, just added this one in. When you've got people that are sitting quite upright, the internal jugular vein will collapse basically to nothing. So don't forget to look for it before you stick your needles in. Sometimes I do deliberately go through it for an FNA if I've got absolutely no option, and I've never had any problems, but I wouldn't want to do that for a core biopsy. So make sure you know where it is before you start doing your procedures, because it can be even more collapsed than that one. It can be completely opposed. So make sure you know where it is. Get the patient to Valsalva before you stick the needle anywhere in that vicinity. And then on a Valsalva, it would blow up like this. That's just word of advice. As I say, it doesn't seem to matter with a very thin needle, but I wouldn't want to stick a core biopsy through it. Next slide. Okay, so that's the end. If you want some bedtime reading, very good for sleeping. This is the book that I used when I was did radiology training. I've forgotten it all now. This is apparently, one of the trainees said, a bit more of an up-to-date modern one. But anyway, if you want to read more about ultrasound physics, there you are. Thank you.